Hello, everyone. Thank you for joining us today. Today we've got Dr. Amarinder, who's in FY2 currently, to give us a presentation on surgical on calls. Sorry, I'm having difficulty speaking today. Surgical on calls. He's actually going to start his ACCS anaesthetic training in the West Midlands area as well. So, Amarinder, are you happy to take over?
Yes, thank you for the intro. Yeah, I'm happy to take over. Can we just confirm that people can hear us? I don't want to speak to the ether.
Yeah, that's true. I can hear you.
Uh, yeah, perfect. That's a good start. All right, let's just wait. I know there's a bit of a delay for other people to hear, but the signal's good.
Can someone just message in the group chat if you can hear us, and see the presentation?
Yep, perfect. Thank you, James. All right, cool. Let's go. Right, so let's get into it. Um, the whole point of this is to arm you with the thought process more so than the medicine behind it when you're covering a surgical on-call as an F1 or even as an SHO, but mainly for F1s. The way we're going to break it down is we're going to go through a few cases and kind of go through the whole story of the patients. They're not going to be medical mysteries. I'm not trying to make you house MD. They're simple cases, but I want you to have a good thought process. And at the end, there'll be lots of times for questions. But if any of you really desperately want to ask something during it, please do, and I will look into it. So let's go. So firstly, the approach to surgical patient. I'm not going to go spend too long on this, but essentially, this is what you learned at medical school. Okay, have a good process. At St. George's, where I graduated, we did the full Socrates, which again, site, onset, etc. And this will help differentiate, obviously, the cause of the patient's symptoms. And it will help you whether it be seeing a new patient fresh in A&E, which is unlikely what you're going to be doing in F1, but also when you're dealing with the post-operative patient or even the pre-operative patient when they're on the wards. Okay, so obviously this is just more factors to keep in mind when you go through the histories. Obviously, we are ensuring we are narrowing down our differentials by asking these extra questions, just to make sure some of you are paying attention. Do any of you know of any conditions, surgical presentations, which get worse, or let's say the pain gets worse when you start eating, especially in elderly vascular patients? This little bonus one. Any takers? Come on, be brave. Peptic ulcers, yes, that's one. Yeah, gastric ulcers. Yeah, that is true. GERD, yeah, we've got a lot of GERD, yeah. How about more so in the bowel? Yeah, there we go. You hit both of them. Excellent. Very, very good. Mesenteric ischemia. Very good. Right, obviously, associated symptoms. Most importantly, my final bullet point. Why is it important to ask the patient when they had their last meal, especially a potential surgical patient? I know it's a bit of a delay, but why is it super important? Yeah, very good, very good, very, very good, because the anaesthetist won't be angry with you. Excellent. Or with the patient, even. All right. This is a very good diagram from an on-call surgical book. It's very good. I just feel free to screenshot it. I can send it to you as well if you email me. It's a nice little diagram of common areas of where the pain is and what organ it's related to. One little bonus with renal colic, there's something known as Giordano sign, which I only learnt this year actually, where if you tap someone, well, I say tap, you get your fist and you just briskly do that. Oh God, 1 minute. Let me just sign up my Telegram. I apologize. There we go. All right. So yeah, if you tap on someone's back swiftly with your fist, it actually causes the pain to very much radiate down from their kidney area to their groin, and that very much is like a clinical sign of renal stones, renal colic. Okay, so let's go on to a case. So a 25-year-old woman with no previous medical history reported to the emergency department with abdominal pain, anorexia, nausea, and vomiting. Could you just throw some things in the chat? What are key things we should ask for this patient if we were taking the history? Just basic things. Yeah, very good, very good. Yep. Excellent. Always, that's the main one, really. Good, excellent. That's the main one. Obviously, the other stuff you guys know with Socrates. Okay, so this is more information. So timing, it began 8 hours ago, and as all of you guys saying, where's the pain? The pain is in your typical fashion, periumbilical to the right lower quadrant. Negative for anything fancy, no hematemesis, no diarrhea, no hematochezia, no melena. Okay. With more stuff that you did, low grade fever, pain upon light palpation of the right lower quadrant. The patient does not want to move. Well, the patient does not want to move during the examination because she is in horrific pain. What is that a sign of? If the patient does not want to move, and also has been a very good recent or previous surgery, excellent. Peritonitis, exactly. Okay, so this is a surgeon's wet dream. Excuse my language. Okay, because this is someone with a peritonitic abdomen. This is 99% they're going to go into this patient, and Rob 6 hands positive. So you pressed on the opposite side, and then you took your hand off, and the patient jumped to the ceiling. Okay, so differentials, we've pretty much gone through them all. Appendicitis, ovarian cyst, ectopic pregnancy, mesenteric adenitis is unlikely. She didn't mention any history of like a previous cold or current sore throat or anything like that. So, investigations. I'm going to ask each of one of these because this is very important because you as the F1 are likely going to be requesting investigations for your seniors, and a lot of the time they're not going to tell you why. Okay, a lot of the time they also shouldn't be doing it because of defensive medicine. That's a different story. Okay, so why would we want a full blood count on this patient? I know it's a very obvious question with obvious answers, but I want to hear it from you guys because I want to make sure you guys are all on track. Anemia, yeah, in case we need to correct it before the surgery. Infection, good. So you want to look at the white cell count and the differentials of white cell count. Sabina, I get what you're saying, but a full blood count won't tell you if it's sepsis. It will just tell you the white cell count. Why do we care about the renal profile? Yeah, you want to look at the white cell count as well as the other parts of the white cell count, so lymphocytes, neutrophils, monocytes, eosinophils. Contrast media use, yeah. Again, if you read recent reports, the whole nephrotoxicity of CT contrast is basically a myth, but yes. Renal profile for contrast CT. What else? Remember, this person, she's got anorexia, nausea and vomiting. What may have that caused? An AKI, exactly, good. Pre-renal AKI, very good. Why do we care? Electrolyte imbalance is very good, very good. Clotting? Why do we want a clotting? Bleeding risk perioperatively, good. Anything we need to correct. It's unlikely in a 25-year-old, but obviously very good. Okay, now inflammatory markers. Which inflammatory markers commonly requested and why? And then remember, I put inflammatory marker. CRP, good. Now, let's say this patient's CRP with this presentation is 3. Does it mean they're not having appendicitis? It is. So if it's within normal range, does it mean they're not having appendicitis? Exactly. Beautiful. There can be a leg. Sumaya, hopefully I pronounced your name correct. Excellent. Right, beta HCD, we all know. You all said it already. We want to make sure this lady is not pregnant. Now, imaging, you likely will not be in charge of choosing the imaging, but you know, it looks good on the surgical ward rounds if you're one step ahead of your senior. Um, which, what form of, there's no one correct answer, by the way. Firstly, with the presentation of the patient, would imaging, which imaging modality may you choose? And let's presume she hasn't got an AKI. All the other bloods are. I'll show you the other bloods in a minute, but There's no one correct answer. So CT, yeah, you can do a CT. Obviously, if you really, really want to quadruple check. Any young woman, what are the alternatives if you have a very skilled individual? You can do an ultrasound, yeah, ultrasound to rule out other diagnosis is excellent because you want to make sure it's not a gynae pathology because they can mimic each other very well. So, yeah, chest x-ray is always done. Yeah, erect chest, very good. So you're all thinking about the same things. You're basically ensuring that you are not missing any of the big signs of an acute abdomen, which you've gone for pneumoperitoneum, you're checking, which can be caused by appendicitis. It could rupture the bowel. You're doing an ultrasound to make sure no gynae pathology, and you can see roaring appendicitis on an ultrasound if you've got a skilled sonographer and the patient is thin. CT would 100% confirm your diagnosis. Some seniors may just take this patient to theatre and they'll have obs and gynae on standby. Anyhow, so I don't need to go through this. We've already gone through it. So the patient is essentially showing signs of inflammation and likely an infection, and that's the markers shown here. Okay, so management, all right, as we all know. Okay, so when you're getting someone ready for theatre, these are things you need to do. Obviously, make them nil by mouth. Do you guys know the timings for food and drink before surgery? 2 hours for clear fluid, emphasis on clear fluid, and 6 hours for food. So if this patient was about to grab a sandwich in A&E, you would rip it out of their hands. Obviously, you wouldn't do that. I don't want you getting struck up, but you would highly advise them to not eat that sandwich. Excellent. Right. Okay. And group and save. Do you guys know what a group and save is and why we would do it? Exactly. Normally, obviously, differs by trust, but obviously, usually requires two separate samples to avoid any errors, and they have to be done at separate times, which can be very annoying for the patient. But you can learn some tricks like drawing it from the cannula. But again, that's offhand advice. Antibiotics before theatre. That's questionable. You can do it. You download an app for your trust called MicroGuide, and your senior will advise you this, but it's not essential because every patient who has a big surgery like this, they will normally be given broad spectrum antibiotics when they're on the table before the surgeon cuts them open, which will cover pretty much all the bugs in the abdomen. And remember, consent, usually people who are able to do the operation should be consenting. So never ever let a senior force you to do consent for a patient, especially for an appendicectomy. You get them to do it, and obviously you can stand there and watch them do it, so you can learn the process as well. If any of you are going to be future surgeons or want to be future surgeons, right? Okay, now maintenance fluid. Okay, so what fluid status should we be aiming for in a patient before theatre? Should they be hypovolemic, normovolemic, or hypervolemic? Any takers? So before theatre, what fluid status would you like your patient to be? Hypo, hyper, or normovolemic? I promise you, look, I'm not asking any trick questions here. Normo, beautiful. Euvolemic. Yeah, sorry, apologies. Euvolemic. Sorry, this is my terminology. Euvolemic. That's what I meant to say. Apologies. Yes, you want them to be normo/euvolemic. Okay? So, in this patient who came in the emergency department, she was anorexic, nausea, and vomiting, you would give her some maintenance fluid. It would just be a balanced crystalloid, like Hartmann's would be fine. Okay? But in contrast, let's say you have someone like myself who's having an elective operation day case. I'm coming from my house and I fasted myself the night before, and I'm first on the list, and I had my last drink of water at 6 a.m. and I'm at the hospital at 9 a.m. Would I need maintenance fluids before my operation? My heart rate is fine, my blood pressure is normal. Exactly, no. A lot of nurses, especially with day case patients, will be bleeping I won't swear, but bleeping you with every elective patient who's come in the night before saying they need maintenance fluids while they're sleeping. Respond to them. You don't drink water while you're asleep, so they don't need water either. Okay? It just saves a lot of time and hassle. Just explain it to them, and also it will give better outcomes for the patient. Excellent, thank you. I hope that's the one takeaway point I want you guys to have. Right. Okay. So this will be something that you guys will be doing a lot as an F1, even on the wards. Okay. So this is the kind of the process that you will need to kind of tick off as you're getting a patient ready for theatre. Obviously, confirm with your seniors, because obviously different operations have slightly different nuances. We've gone through the big three at the top. Okay. Now, anticoagulants. All right, in today's world where everyone has 4 million comorbidities, loads of people are on anticoagulants. This website is a UK based website made by pharmacists and anaesthetists. I will link it actually in the chat for you guys. Pre-operative. I know you guys can see handbook. Oops. Okay. Okay, because this is really good. Just so you guys can look at it. Okay, so essentially it's a website which gives you guidelines for all medications before an operation, but usually anticoagulants you will be stopping. Okay, so that will be whether it's the heparin, warfarin, etc. And this website guides you through it very well. If it's someone who's a bit more complicated, please ask your local pharmacist about this. But this website is literally the holy grail, and it's updated constantly with the latest guidelines. Okay. Stopping more niche medications, normally the anaesthetists do it. That's what they did at my trust. But if it does fall to you, make sure you ask them for advice. They're the experts. They like to stop ACE inhibitors the morning before the operation because it's very prone of causing someone to be hypovolemic. If someone is a diabetic that normally needs to be controlled with insulin in the community, normally you start them on a variable rate insulin infusion. Okay, so that normally is you keep their long acting insulin prescribed, and you start them on the variable rate insulin infusion, which is normally a guideline in the hospital, which you just follow. I think if I remember correctly, Shruti and the team have done a talk recently on management of crazy BMs already, and I think it's on the Mind the Bleep YouTube channel. So give it a watch. Shruti, please correct me if I'm wrong.
Yeah, that's right. So the webinar before this on Friday, we did tackling hypoglycemia and hyperglycemia, and that's on YouTube as well. So you can definitely have a look at that.
Cool, thank you. So just to prove I wasn't talking rubbish. Excellent. So yeah, have a look at that one. Usually with colorectal surgery, they like to give the patient bowel prep, so like Picolax, etc., to empty the bowel to minimize fecal contents going into the peritoneum for obvious reasons. You're going to start the VT prophylaxis, which is TED stockings and low molecular weight heparin injections. Okay, usually that's prophylactic dose, but again, confirm with your senior, check the patient's comorbidities. Antibiotic prophylaxis, run it by your senior and check microguide. The last thing is this NELA score. Okay, your senior will confirm the link they want you to use. This is what I used at my hospital, and essentially you just put in. It's very self-explanatory. You fill in a number of numbers before the patient's operation if it's a laparotomy, so if it's an open operation, and it allows us to calculate a risk, and also it puts the patient's operation onto a big audit that's done nationally, and obviously surgeons go through it later on. So when you're bored, which I know none of you are, you're all getting ready to be doctors in the real world, have a look at the NELA website, because for me, it's interesting. It may not be interesting for you, but it's good to know, especially if you're about to start a surgical job. I've spoken a lot, and that slide is very busy. And does that all make sense so far? I don't want to run off and not have all of you on track. Excellent. Thank you very much. I will continue. All right. Beautiful, beautiful, beautiful. Right. Okay, got another case. Okay, right. The cases are all going to get shorter and shorter because we've done a lot already. So, case 2. A 40-year-old obese woman with a history of gallstones presents with epigastric pain, fever with chills, itching, and her friends have noticed her eyes are yellow. Any questions, or if you want to throw out a differential, go for it. It's fine. All right. Remember, the whole point is management of the case. Okay. Remember, your doctor, you're here to manage it. You are probably pros at diagnosing already. I'll be real with you. Pancreatitis, yeah, very good differential. Ascending cholangitis is very, very, very good. So this is your classic medical school STEM. All right, we've got someone. She fits the F's of fair, female, fat, 40, etc. Okay, she's got Sabina, very good, very good. She's got the chills. She got the jaundice. History of gallstones, as I said. Okay, so we're thinking of ascending cholangitis. All right, so she has likely an infection, biliary tract infection. Excellent. You'll see. Look, I knew you'll get it. Easy peasy. Right. Okay. So, Sabina, I've answered your question. Well, most of your questions. Okay. So, history reveals pale, floaty stools and very dark urine. Okay. This is because the bile isn't actually, going down into the small bowel, so she's not actually absorbing any more fats. All right, and obviously it's leaking into the blood as well, the bilirubin. So examination reveals jaundice everywhere, okay, especially in the eyes, scratch marks, tenderness in the right upper quadrant, but no palpable gallbladder. Okay, this is the classic differential. How to differentiate them all if you're ever in a pinch. Okay, biliary colic would just be right upper quadrant pain. Acute cholecystitis would be right upper quadrant pain and fever with no jaundice, and ascending cholangitis has everything. Okay. So, you're examining this patient, okay? She's got very high temperature, tachycardic, blood pressure is quite low, respiratory is quite high, SATs are 96, and GCS is 14 out of 15, E4, V4, M6. Would you be, would you be scared about this patient, or would you just be like, all right, cool, or would you just, just give her some paracetamol and get on with your day? Okay. So Sabina, you're very correct. But what is your working diagnosis for this current patient then? Sepsis. Okay, good. All right, sepsis is fine. So she's clearly got a systemic infection. It's serious. Good. So what's the etiology? What's the cause of sepsis? Sabina, you are surgery. You are surgery now. Ascending cholangitis, good. So biliary sepsis is the cause. Okay. So what special bundle of stuff are we going to give this patient, and what are we going to do? Are we going to do it on our own? Are we going to call for help? Remember, you're on F1. Doesn't mean you're not capable, but you only have two hands. So let me start off with the first question. Yep. So who are you going to call for help, James? Who? I can scream for help, and the HCA comes in. Well, how's that? No offense to the HCA, but you're the F1 on general surgery. Who are you going to call for help? Very good. Go. So call your surgical SHO, reg. Call everyone basically. Call your surgical SHO. Call your reg. Call the ITU SHO. Excellent. Okay, that's why I wanted to make sure. Don't do anything on your own. Good. Surgical reg needs to know about this patient. Good. Yep. Excellent. Right. So what needs to be done? Okay. As you said, we need to stabilize. You told me the people you want to call as well. So I'm going to break it down now. Okay, so sepsis 6, everyone knows about it. We are pummeled in the head about it at medical school. Evidence behind it is questionable, but anyhow, okay, we're not here to do a journal club. Okay, right, so the first thing, so sepsis is we give 3 and we take 3. So, what three things are we going? So, what three things do we normally take from the patient? So, usually it's blood stuff that we take from the patient. Yes, beautiful, Sabina. Very, very good. Very, very good. So, yep, very good. And then obviously, I know you guys have mentioned it. We're going to give oxygen, we're going to give fluid, and we are going to. My brain has now stopped working. We're going to give oxygen. We're going to give antibiotics. Now, it's very easy and very good to tell me you're going to give broad spectrum antibiotics. Fine. Okay. What bacteria do you guys think is causing this infection? It's very good to know which bacteria it is, because then you can be a bit more skilled in which antibiotics to use. But if you say tazocin, it's fine. It's still correct. But what bacteria is the common cause of biliary sepsis? Gram negative, yes. Could you give me the name? E. coli, very good. Okay. Where gram negative enteric typically is E. coli, unless someone's really unlucky. So usually E. coli, bacteremia leading to sepsis. Very good. Very, very, very good. Okay. Now, IV fluid. So, okay, fine. You told me you're going to give fluid. Remember, you're going to be prescribing it now. So, how much fluid are you going to give in this scenario? What are you going to do at the bedside? I'm the nurse. I give you the drug chart. Doctor, how much fluid do I give this patient? How fast? Good. Fluid challenge, 500 milliliter stat. Yeah, so whether it be Hartmann's, normal saline, well, a 0.9% saline. Very good. So, James, very good. Yes, so you're going to give 500 milliliters and you're going to reassess. What are you reassessing? So you're giving a fluid challenge, which is excellent. That's what I wanted to make sure. So what are you reassessing? Urine output, vital signs. Good, good. A to E, yep, yep. So essentially, you're seeing if the increase in perfusion from the fluid is having any benefit for the patient. Okay. Now, just a rule of thumb. Okay. If after giving a total of like 1 liter or 2 liters, the patient is nothing's getting better for the patient. Okay. Obviously, you guys have already called ITU. You're brilliant. Call ITU then. Okay. Because giving more and more fluid is likely going to cause worse outcomes than good outcomes. Do you know what complications can occur if we give too much fluid to this patient or any patient? Hypochloremic acidosis, yes. That's if you give too much 0.9% infiltration. Yeah, hematoma. I get where you're coming from, but not so much in this regard. Um, what's a classic? Not embolism. Flare. We go, Stephanie. Thank you. So pulmonary edema and possible heart failure and extravasation of the fluid into all the tissues. That includes the organs that you can't see on the bedside. Okay, it leads to edema in the kidneys, edema in the bowel, edema everywhere. Okay, it can lead to multi-organ failure. Excellent, good. That's why you should always be careful. Okay, don't just keep pumping someone full of fluid if you're not getting any improvement in their clinical state. Okay, so oxygen again. Okay, give it and titrate it accordingly. Okay, antibiotics. We've already gone through that. Blood gas. You guys have already said you're assessing for any lactate to assess any reduction in perfusion. Okay, right, very good. So before I go on to this next case, pretend you're not looking at this slide. Did that case make sense? Okay, that case was meant to be dealing with the acutely unwell patient, because this can happen on the ward. It doesn't have to happen in A&E. Very good. And remember, in an emergency, well, to be fair, in all cases, always ask for help, okay? Asking for help is a sign of a safe and a wise individual, okay? Remember, you have two hands, yeah, you have a very good brain, but always ask for help. It doesn't hurt. Yep, Tazocin is a typical antibiotic you would give. Again, consult your local microguide guidelines because different hospitals like different things. But if you were just going off your head and giving Tazocin, Fibrocin, and Tazobactam, it would be correct. But in the later on during the week, you would want to change it to an antibiotic which will be treating the suspected bacteria. And a common bundle is comoxiclav and gentamicin. But that's going way beyond the course of the talk. I could talk about antibiotics for years. But yes, exactly, Janthi. Hope you pronounced your name correct. Right, last pre-op case, and then we'll go on to post-op. Right. Okay, nice simple case. 18-year-old man woke up at 5 a.m. one morning with severe testicular pain. What is our can't miss diagnosis? So let's go for that one first. So what's the diagnosis we can't miss in this scenario? Young man with testicular pain. That pain was so bad it woke him up. Testicular torsion, very, very good. Now, bonus points. What clinical examination should we do? And don't just say testicular exam. What signs are we looking for? Yep, attempt to elicit the cremasteric reflex. Excellent. Okay, so essentially you rub, obviously have a chaperone with you. Essentially you rub the inner thigh of the gentleman, and you want to assess if the testicles are essentially churning. Okay, because if they are not, it likely indicates lack of blood flow to the testes. And Sabina, very good. You're talking about the Pren sign, so obviously lifting up the testes can sometimes relieve the pain. If it's caused by something else. But yes, you're very correct. Very good. So who are you going to call in this scenario? Remember, you're the F1 covering general surgery out of hours. Who needs to know about this patient? Which senior in particular? I've just given you the nerve endings as well. Who? And just what bell clapper position is when the testes, instead of being upright, it twists on its axis. And you may feel that underneath the skin. But yes, who is the senior we need to call? Which speciality? Surgical, which specific surgical? Urology, red. Excellent. Okay, because time is testicle. Okay, we need to do an operation. All right, in order to prevent this poor individual potentially losing the testicle. Okay, so when you take your history or when it's handed over to you, you want to know the exact time ish that the pain started. Okay, because the clock starts. We need to know where. All right. Usually, you guys won't be in charge of the workup. Usually, the surgical reg will be running in and sorting out this patient. If imaging is done, which theoretically it shouldn't, but if imaging is done, which imaging may you want to do to rule in or rule out the diagnosis? Yep, Doppler ultrasound. Essentially, you want to see blood flow into the testicle. All right, very good, very, very good. Okay, so that is the final pre-operative case. It'll be an ultrasound, Heba, but anyhow, yeah, exactly. Surgical exploration is the fix. Right, so before I go into post-operative stuff, are you guys happy with the pre-operative cases that we have gone through? Yeah, Morella, you said the exact words. Ultrasound Doppler if it doesn't delay surgical exploration. That's 100% correct. Excellent. Right, let's go on. Right, okay, so remember that 40-year-old lady, that our septic lady from case 2, after her extended hospital stay where she had to go to ITU, she was discharged and finally managed to have an elective day case laparoscopic cholecystectomy 4 weeks later. So she got stabilized. We did an ERCP to, calm down her biliary tree. We discharged her. We let her get a bit better. And now she's coming to the hospital from our house for a day case cholecystectomy. Okay, we're waiting for all the inflammation to die down. So the patient ends up on the ward, which you're looking after as the F1. The surgical notes say it was deemed a success. There was no immediate complications, and your consultant says, "Yep, she can be discharged later this evening." However, sadly, about 3 p.m., the nurse bleeps you, stating that, "Hold up, Mirella, let's calm down, calm down." The nurse bleeps you, stating that 4 hours post-operatively, it is really difficult to wean her off oxygen, and her SATs go down to 85% when the oxygen is turned off. All right, Mirella, don't remember. Let's not jump. Let's not jump to conclusions. Okay. What? So let's. So the nurse has given you this phone call. Okay. What do we think about as we talk to the patient? So we have a patient who has low oxygen saturations few hours after their operation. Okay, so it's very, very, very acute, this complication. Okay, potential complication. So, Morella, I presume you're talking about pulmonary embolism. That's one potential differential. What other differentials could there be, guys? Remember, this is very acute, a couple of hours after the operation. Mustafa, very good. Yeah. Any others? Okay, so post-op hypoxemia is just a physiological state. It's not really a diagnosis. Yep, pneumothorax, pneumonia. Yep, they all could be one. So it would be a hospital-acquired pneumonia. Atelectasis, we're going out there. Very good. So, okay, fine. We're going to be walking to the patient from wherever we are. What could we ask the nurse to do before we arrive? And just to make your life easier, this nurse um, is a theatre nurse, so she's basically an ITU nurse. So she's trained at taking blood. She can take blood gases if you need. So you've got the dream nurse with you. Poor perfusion to SATS probe, very good. Abdul Karim, very, very good, very, very good. Abdul Karim. ABG, yeah, very good. What else would you ask the nurse to do? Right, this person's at 85% on room air. So what mask would you tell the nurse? Probably has already done it, but what mask would you put on this patient? Non-rebreathe mask. Excellent. I think yeah. Hope I pronounced your name right. Very, very good, guys. Very good. Very, very good. Okay, so you get to the patient's bedside. What are you going to do? And the oxygen's on, by the way. You get to the patient's bedside, the oxygen's on. What are you going to do? Beautiful. A to E. Beautiful, beautiful. All right. Here we go. Right. So, patient's upright in the bed with a non-rebreathe mask on. With the non-rebreathe mask on, her SATs are pushing 98%, and the SATs probe signal is very good and corresponding to her heart rate. She's complaining of annoying right shoulder pain. Okay, as I'm holding my right shoulder, yes. So why is she complaining of right shoulder pain? Very, very common. Yes. Why does she have some pneumoperitoneum? Why am I not concerned about the annoying shoulder pain? Diaphragm irritation from what? I'll go back. I'll go back. I'll go back. I'll go back. So she had a laparoscopic cholecystectomy. Yes, Beverly, very good. Do you want to expand on that? So exactly, yep. So gallbladder export, very good as well. So exactly, very good. So whenever anyone has a laparoscopic surgery, yep, the gas is used to inflate the patient's abdomen, and obviously that gas can cause diaphragmatic irritation, especially with a lap chole, and it can lead to annoying shoulder pain. Okay. So you listen to her chest. There's no wheeze. Okay. She is taking quite a few breaths in between sentences when you're trying to chat to her. When you listen to her chest, there's reduced air entry bilaterally with some crackles. You look at the abdomen. Okay, there's no drains or anything in there, but the dressings are clean. and there's a little bit of pain at the port sites, but there's no pain on deep palpation. The patient is moving around. Okay, so there's no signs of peritonitis. So apart from an ABG, what immediate investigations would you want? Usually at least about 24 hours, to my knowledge, Morella. Or I don't know why they crackles. You tell me. This is what investigations are we going to do? Yes, I like it. Erect chest x-ray as well as the ABG. Good. Good, 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 good. I'm happy with that. So okay, let's get a bit more practical now. The patients in the post-op area, would we wheel this patient down to x-ray or would we call them up? What would you do? Just a bit of practical stuff. Exactly. You would want a portable bedside x-ray as soon as possible. Very, very good. Okay. And I'm not showing you the ABG because it's kind of irrelevant to the case. We already know the patient's hypoxic from the SATS probe. All right. But if the ABG was done, let's say her PaO2 on 60% oxygen is 20. Okay. So she's obviously hypoxemic. All right. So this is the chest x-ray that was done. Obviously, sadly, I couldn't find a picture of a lady, but let's pretend it is. Okay. Anything normal or abnormal in this chest x-ray? Again, just say what you see. I'm not here for a diagnosis. I just want you guys. Okay. Any other takes? All right. Oh god, my mouse is awful. Right. Yes, James. Okay. Okay. Yeah. I'm hearing things. Any other takes? Obviously, it's not the best picture for you guys. Yeah, okay, fine. We're getting there. Right. Okay, yes, Sabina, very, very good. Okay, so Heba, just to answer your, just to refute your diagnosis. So underneath the diaphragms on both sides, we see no darkness below the diaphragms. That's why it's not a pneumoperitoneum, okay? Below the diaphragms on both sides, it's nice and white. So from the chest x-ray, there's no obvious air underneath the diaphragm. So pneumoperitoneum is not seen on this chest x-ray. The rest of you guys, you are correct. There appears to be some hyperdensities bilaterally at the bases of the chest. Okay? So what are we thinking now so this is not a normal chest x-ray. Okay? So what are we thinking now about? What diagnoses have we ruled out? What diagnoses have we ruled in? But it's fine. That's the whole point. We're here to learn. The most important thing is you took part. Okay. Right. So, what diagnoses have we ruled out? Obviously, we ruled out pneumoperitoneum. What diagnoses have we ruled in? Pleural effusion is not fully white in that area, so I wouldn't say pleural effusion. Yeah, aspiration. It could be a HAP. We could be in a HAP that we're dealing with. Aspiration pneumonia. Yeah. Anything else? You guys have said it already in your differentials. Yes, Ravni. Very good. Atelectasis. Okay. Right. So, I wouldn't say there's a pneumothorax because we can see the lung tissue on both sides in both lungs. So atelectasis, aspiration are our main differentials. And on the next slide, I've circled the things you guys have already talked about. There's some hyperdensities here. We've ruled out pneumothorax. Excellent, Morella. Yes, we have. Okay, so Oops. Right. So the likely diagnosis in this scenario is atelectasis. Okay. This is so emphysema wouldn't. So number one, she doesn't have a history of smoking. Number two, she doesn't have a history of COPD. Number three, emphysema wouldn't present acutely like this. Emphysema is a chronic condition. Okay. So now the chest X-ray that we have here shows hyperdensities and bilaterally. Okay, and it's very difficult to correct with oxygen, which is in keeping with atelectasis. Now, the reason why I'm saying it's unlikely to be pneumonia because immediately post-operatively, the most immediate complications are with the chest atelectasis. Other immediate complications otherwise are like bleeds, etc., which the patient is not experiencing. Okay, things like pneumothorax usually occurs within or the latter period, so within 4 to 10 days. Pneumonia normally occurs within 3 days. Okay, things you would ask the patient is, was the patient vomiting furiously after the operation? Obviously, I didn't include that in the history, but that wasn't occurring, so it's unlikely to be aspiration. Also, she's a young 40-year-old woman. Hopefully we won't be worrying about swallow. Okay, so I hope that answers the questions. So before I go on to things we shouldn't miss in post-op review, I know that case was a little bit challenging. Did you guys like that case? Did that help with the thought process of dealing with the hypoxia post-operatively and hypoxemia? Be honest. If it didn't, please be honest with me because then I can improve it. Excellent, excellent, excellent. Thank you, thank you, thank you. All right, cool. Let's finish off the talk and then I'll open the forum to questions. So, post-operative review. When you're reviewing anyone post-operatively, ask the nurse to bring the patient notes, especially the op notes. Okay, you want to know what. So again, so Joanthony, pneumothorax normally occurs immediately, and it would be seen on the chest X-ray. And no matter what, you'd always get a chest X-ray. Now preparation. Obviously, you want to get the post-op notes. Okay, you want to make sure, even though our senior told us that the operation went fine and there was nothing funky that they did inside the abdomen. Drug charts. Now, you want to see how much fluid the patient had intraoperatively. Okay, because obviously pulmonary edema can be a complication post-operatively. But again, normally the anaesthetist is in charge of the fluid there, and that normally wouldn't occur. PRNs. Now, these are drugs as needed. So, why should we check if the patient has asked or taken their PRNs, especially in a patient who has atelectasis? So, PRN meds typically are your analgesia, so your paracetamol, your Oromorph, your NSAIDs, the other funky stuff. Why do we care? Obviously, we don't like patients in pain, but why is that very relevant to atelectasis? Think a little bit laterally, guys. Yes, excellent, Victoria. Very, very well done. Yes, you hit the nail on the head. Right. So, yes, opioids and respiratory drive, very good. I would hope that the patient hasn't been given a lot of opioids immediately after the operation, but you're very correct. They may be opioid naive. They may be very sensitive. Very, very well done. Excellent. Very, very good. So, back to Victoria. Yes. So when someone has immense abdominal pain or even chest pain due to other causes, I'm not saying the patient's having an MI, it's very difficult to expand their chest like us we're doing now. Okay. Therefore, parts of their lung, especially after being ventilated for an operation, especially a long operation, parts of their lung will be collapsed, but the alveoli will be collapsed like this. They're not open. Okay. Therefore leading to atelectasis. So the best treatment for atelectasis in this example is sitting the patient upright if possible, making sure their pain is under control, okay, and when during the day hours, giving them good chest physio, okay, and early mobilizing. Exactly, Morelli. You want good pain control. Obviously, in other patients, you want to get the fluid charts, obviously, to see if the patient's getting enough fluid or not getting too much fluid. And lastly, you want to check the drain charts. Okay, you want to see what's coming out the drains. Is there some weird pus coming out there? Is there frank blood coming out there? Or is it just normal hemoserous fluid? Okay, so it's always good to check. Okay, obviously these are the things you want to do. Now, my question at the bottom, which I didn't put a question mark on, but why would you be cautious about doing hemoglobin, white cell count, and CRP within 2 or even 5 days post-operatively? Why? Obviously, seniors may tell you to do it no matter what. That's not good medicine, but we're all very clever individuals here. Why would you be cautious about doing an HB, a white cell count, and a CRP in the immediate post-op period? Yes, Sagana, beautiful. So CRP will be elevated no matter what in the immediate post-op period. So getting a CRP is not going to do anything. There will always be inflammation. Very, very good. And similarly so with white cell count. Essentially, a knife has been on the patient. They're going to have inflammation even if it's a non-infective operation. Why is it a bit questionable to do a HB immediately after an operation if you're querying a bleed? Why may it misjudge your management? Let me put it that way. If you do a HB, why might it falsely reassure you? And I sadly learned this the hard way as an F1, but yes, Jonathan, beautiful. So now, if you're thinking someone's having a bleed, an acute bleed in front of you, if you take their blood straight away, let's say within an hour of their bleed occurring, their HB will not change. The reason why is that HB obviously is a measure of the concentration of red blood cells in your body. When someone's acutely bleeding, they're losing both blood and plasma. So the concentration doesn't change. Okay, because the volume of fluid that the blood is carried in has decreased as well. So when you are potentially diagnosing an acute bleed, the clinical picture is what you use. So is the patient ridiculously tachycardic? Is their blood pressure going down? Is there blood coming out of their wound site? Is there blood in their drain site? Okay, that's the reason why. Okay, I hope that makes sense, and I hope I explained it correctly. If not, then ask Jonathan. But yeah, I hope that makes sense. And if it doesn't, please do tell me in the chat. And I promise you we're nearly done as well. Does that make sense, guys? Okay, I presume that makes sense. I will continue. Right. So, me and my colleagues, we did a series on perioperative care in great detail, which was done by numerous anaesthetists, ITU consultants, surgical consultants, as well as myself and my colleague. The link is there. It's on the Mind the Bleep website. I can't really copy and paste now. I'll put it in the chat later on. I'll link it to you guys later. So if you have any major queries on the niche side of surgery, which will probably bore a lot on perioperative care, it's all in that series that we did. The analgesic ladder, okay, make sure you prescribe it, okay, when a patient needs pain relief. Obviously, be cautious with the NSAIDs if patients have history of upper GI bleeds or kidney issues, kidney injuries. Fluid balance, always aim for normovolemia. Mind the Bleep had some excellent resources on how to prescribe proper maintenance fluids. And more importantly, when it's normal hours, speak to the physio team, and they would love it. Seriously, they love it when we advise them which patients you believe would benefit from fixing their atelectasis or even preventing atelectasis with their help in the post-operative period. Remember, early mobilization and good pain relief is the treatment for atelectasis. Okay. So this is pretty much the end of the main talk. Okay. Remember, always ask for help early. Do the basics well. Okay, that's what we want from you as an F1. Okay, and understand what you're doing. Okay, if there's any time a senior tells you to do something you don't understand, question them. Okay, you're not trying to be difficult. You want to make sure you're on the same page. Then you can do the job properly and have the patient has a good outcome. And lastly, this famous phrase: when you hear hooves, think of horses, not zebras. All right, I know in med school we learn all the rare stuff. Okay, we learn all about hemochromatosis and Mediterranean fever and all these weird causes of abdominal pain. It does exist, okay? But when you're in the hospital, think of the obvious things first, okay? And then consider all the rare stuff later on, okay? So I've got some extra slides later on, which will whiz through. Do you have any questions? And yes, I'm done, Fruity, sorry.
No, I just want to say thank you very much. But then
That's
I
all right.
realized you've got a couple of slides after as well. So I'll
No,
run
no,
into
no, no. I'm not going to go through them that much. I'm just going to whiz through them. But yeah, are you able to hear that? You, yes, 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 yes. I will do more. In I'll go now. I know you guys are seeing my screen. I apologize.
When I upload this onto YouTube, I'll also add in a end slide, end sort
Cool.
of video thing that links to your YouTube video as well.
Wicked. All right. Mind. There we go.
Can you guys also please take your time to complete the feedback form? It should take about 2 to 3 minutes. This would be really helpful for us and helpful for Amarinder as well for their portfolio building, so that we can, create more useful webinars for you guys. Thank you.
Oh God, Shruti, maybe you have to help me out with this question. Are there any
Okay.
other types of tasks that you get called to do a lot during a surgical on-call shift without causing PTSD? Oh.
Mainly it's like perhaps prescribing their regular medications if that wasn't done by the clerking team. Pain medications, someone is vomiting, some antiemetics. Reviewing unwell patients is a common theme, regardless of medicine or surgery or any other specialties. Those are the main things. And during an on-call shift, you shouldn't really be asked to speak to patients or family, relatives, or anything like that, unless it's a patient who's really unwell and that needs to happen. So any sort of ward patient who's quite stable and they want you to talk to a relative, you can sort of prioritize depending upon your job list that you have. So feel free to say, I'm quite busy at the moment, can't quite speak to them, and make sure your communication is very clear, and clear and open with your colleagues, whether it be nurses, HCAs, etc. But yeah, nothing out of the blue really on a surgical on-call shift. You get a lot of it's just reviewing unwell patients, but you should also know your local sort of protocols. So in our department, if someone's using a 5 or more, they should definitely be reviewed by the surgical registrar. So make sure you do escalate things to your registrars and your SHOs as well.
I can't add anything to that. That caused a lot of PTSD, but yes. That's what you normally do. To Maureen, this is a book I got. I won't say how I got it, but you guys know how the internet works. This is a nice book which goes through some on-call scenarios for surgery. Yeah, if you just want to have a more concrete thought process, but nothing can beat you doing it in real life. And as said in my last slide, do the basics well. That's all you need to do.
Just a question from Morel. I'm not sure whether it was answered a bit earlier. If someone has short-term memory loss and they're prescribed analgesia, PRN, but keep forgetting to ask for it, do you keep checking in or change it to regular prescription for the first few days? Anyone who's coming in under a surgical admission should be having regular analgesia and regular antiemetics prescribed. Because otherwise, if they're not in pain, they wouldn't be here and they could be, I don't know, taking paracetamol at home. So whoever it is, make sure you have your analgesia prescribed. Like, so what I would do as practice is regular paracetamol, regular codeine, depending on their age, kidney function, all that stuff, and then PRN, morphine or oxynormal, whatever it is that is suitable for the patient. So you have that, so that you also don't get bleeped asking for pain medications later on, when you're in the middle of something. So that's one way of doing it, and also antiemetics. We give one regular cyclizine and PRN on ondansetron, for example. It's just, if someone coming in for bowel obstruction or something, they're going to be in so much pain, they're going to be vomiting, etc. It's just better to put it on the chart, and then they will give it when it's required.
And
Would you
laxatives as
agree with
well.
that? Hey?
Yeah, I agree. I said laxatives as well.
Oh, yeah,
Yeah,
definitely laxatives.
yeah. Did a war. I've
Helpful tip
I never did
for
orthopedics.
TMO.
I did ortho Jerry's. Never did orthopedics.
I did orthopedics as an F2. So often in orthopedics, the F1s are supernumerary. So I think mainly you would be doing ward jobs. So make sure, I think with any surgical jobs, your ward rounds are going to be very fast. Just make sure that you've got a really succinct way of writing your ward round notes, like a template and stuff. If you're using like EPR or some electronic records, make sure that you can sort of create this fancy way of pre-writing the headings of a ward round beforehand, so you can create these shortcuts and stuff that would help with time. So make sure your ward round's succinct. And for TNO, it's all the same bread and butter, really. It's nothing extra. Just make sure that for surgery you really look out for VTE management, because that's really important. Know for which surgeries you need which VTE prophylaxis and for how long. Like, for example, a total knee replacement might be completely different to a total hip replacement in terms of the anticoagulation that they use and for how long and duration and stuff. So make sure you're up to date with your local protocol, and they should provide you this during your induction week and stuff like that.
Yeah. The many questions about medicine, I could go on forever, but there are many talks Mind the Bleep has, and they can answer. If you really have a burning question, you can email me. My email's at the beginning. Heba, the IMG stuff. Shruti, I presume you're not an IMG. Neither am I.
No.
I don't. There have been a few Mind the Bleep talks though on it. Have a little YouTube search, and they've got some good stuff on it as well as some articles. And Sana, again, I don't want to bore everyone. You can email me about that if you have any burning questions.
We've had a medical rotation sort of on-call session last week, so do have a look at those webinars that's uploaded onto Medal and YouTube. And also we had a sort of prioritization / organization webinar as well, which goes through like how to prioritize your workload and all that stuff, like that's required during your job. So maybe that might be quite helpful. But for specific tips, I think best to pop an email to Amarinder.
Yeah. What I'm going to do now is literally I'm just going to flick through each slide for a couple of seconds so it comes up on the YouTube video. I'm not going to read through them because everyone's going to fall asleep otherwise. Okay, so this is purely for recording purposes. Okay, let me get there. We go. All right, there we go. So I'll leave it for a few seconds. There we go. The one slide I think you guys will actually find of some use. Again, I will do that. Ignore my little burn towards surgeons, but that's a different story. Yep. Again, very good. And this is the slide. Feel free to screenshot it. This is sadly in the hospital I worked at. It lives in the 1970s, so we still have patient notes written by hand. This is the way we would organize the ward entry. This was actually done by my friend Alan, who made this. Feel free to screenshot it. You will have your own flavor when you're at your hospital that you'll make yourself, but this is a nice template to go by. And that's it. Thank you so much for listening to me drone on for an hour, guys. I hope it was of use. And if any burning questions, you've got my email at the beginning, and I will write my email here. Please don't spam it.
Just one final question. Any tips for starting an author Jerry's rotation?
Oh, author Jerry. Look, so Sana, I'll be real with you. Most geriatricians are lovely, okay, and they'll be holding your hand throughout the whole placement. Really, the main surgical tips I've given you apply, but you won't be dealing with most of it as you're the medical team. The main tip I will give you is alongside your assessment of the patient, never ever forget to pull up the covers, pull up the gown, and look at the hip operation wound site, because with the geriatric population, gnarly stuff can happen to the wound site, and never miss it. That's my main tip.
Yeah.
That's it for now.
Well, thank you so much once again,
Cool.
Amarinder, for
Thank
your
you.
time, engaging presentation. And if the audience members can also complete the feedback form once again, that
Please.
would be greatly appreciated. I'll let it just going on for a little bit of time so that everyone can complete the feedback form.
Yeah.
But besides that, that's it from me, really.
Cool. Likewise. Right. See you later, guys. Good luck. All right.
Thank you.
Bye.